You can talk even louder. Okay, good. I have no relevant disclosures, if I can move this along. Good. Okay. So this is the kind of typical case that we actually see every day. This is a 62-year-old gentleman. He's otherwise healthy. T2, N2, MMR proficient sigmoid cancer. He had an LAR and ileostomy 6 months ago, Cape Ox for 3 months, and now he presents this 1.4 centimeter lesion in segment 1 and 8. Does my mouse not work? My mouse work in there? Okay, you'll see in a moment there'll be a green spot. Did you see it there, guys? Okay, so there's a green 1.4 centimeter lesion segment 1-8. You know, surgery will require major operations. It's a very technically difficult area. And so the question for this patient is, would you ablate or resect? Okay. I'm gonna just show another case to give a different flavor of the same kind of problem that we deal with. This is a 57-year-old gentleman with solitary metachronous metastases, T3, N1B, tumor, MMR intact, cecal cancer, and he presents with a lesion in the posterior aspect of segment 7, 2.5 centimeters, not as well seen on the CT scan, but you can see the posterior aspect of the MRI. Can you guys see it there? I can't point anything, okay? And so his operation will require posterior sectorectomy. And of course the question is, would you ablate or resect? So maybe with this show of hands, for case number 1, which was the one with the small lesion here, who would resect that? Everyone? Would anybody ablate that? Yeah? 1, 2, okay. I mean, I don't think it's unreasonable. I mean, this is a tough spot. It's a small lesion, and we'll probably get through some of it. What about this one, second one here? This is 2.5 centimeters posterior sector. Who would resect that? Who would ablate that? Okay, great. So, you know, I think we're going to find out from Dr. Trankau what he would do.
All right, thank you very much, Alice. Okay, so I'm debating today the surgical side of the debate. So according to the survey from the room, I think I'm already on the winning side. So that's good. Let's get started. Next slide, please. Oh, I have control. I apologize. All right, so I have no disclosures. I do want to say I am very honored to be here today and to debate the great esteemed Dr. Warner, who couldn't be here today. You all know her. She's the HB heroine, the queen of the Twitterverse, and a truly all-around awesome person with whom I've become quite good friends. I know that if she could be here, she would be here. Last month, she braved the elements and flew on a single-engine airplane out to Miami to attend the AHPBA, so I have to take it that it's out of service. And one thing I've learned from her pictures is that apparently the cool way to take pictures is at an angle, so I will try to do that from here on out. So I'm not going to tell you the data about surgery for colorectal liver mets because I think that's been very well established. The data I'm going to look for instead is to see, is there really equivalence between ablation and surgery when it comes to the treatment of colorectal liver metastasis? And this truly is a story of extrapolation gone quite extreme. So, you know, the only data to support any ablation for any tumor in the liver was radiofrequency ablation for hepatocellular carcinoma on the basis of some really fundamentally flawed randomized controlled trials. And I know, Sean, I've heard you talk about this to some degree already. Small sample size, lots of crossover, lots of protocol violations in these trials. And then people were saying, well, if it worked for HCC, it should certainly work for colorectal liver mets, right? And then from there, hey, you know, microwave ablation is a lot faster than radiofrequency ablation. If radiofrequency ablation worked, it should work for colorectal liver mets. Microwave should as well. So let's look at the data, right? What is the data? Well, it's a relatively data-free zone, to be honest. There's no high-level data to support the use of RFA for colorectal liver mets. And the meta-analysis that has been done, a systematic review of the literature, concludes that resection remains the gold standard in the treatment of colorectal liver metastasis, should not be replaced by ablation at present. And even when you just focus on solitary colorectal liver mets, like the cases that Dr. Wei presented, the data seems to favor liver resection when it comes to progression-free survival and overall survival, the data that we really care about. How about microwave ablation for colorectal liver mets? I suspect Dr. Warner is going to sing the praises of microwave ablation and tell you all the great things about it that make it superior to radiofrequency ablation. But at the end of the day, the proof is in the pudding, as they say, and there is no proof. No high-level data, again, to support microwave ablation for colorectal liver mets. There are some ongoing trials. And again, when they did do a review of the literature, what you see is that when it comes to local tumor recurrence, the data is clear and favors hepatic resection over microwave ablation. And all the oncologic metrics that we care about, survival data, certainly favor hepatic resection. So when I sit back and think about how we got to this point where ablation is now being used and being debated in this forum for treatment for colorectal liver metastasis, it's a little bit of this going on. You know, what started as a true scientific, data-driven attempt at finding a less invasive approach to treat aggressive disease of colorectal liver mets has morphed into this Hulk smash phenomenon where any tumor that you don't feel like resecting, you're just going to start ablating. Now, I say that with a little bit of tongue-in-cheek, but to be honest, I have seen a number of patients, and I'm sure you all have as well, refer to me who should have undergone surgery a long time ago and now comes in with, damages from ablation or recurrences along the ablation margin. I think we can all agree that there are certain limitations to ablation. There's a size limitation. The data shows that it's most effective for tumors less than 2 centimeters, some would say 3 centimeters. There are location limitations, right? So near a portal pedicle, you run the risk of injuring the bile duct, like you can see in this case here. Near the veins, there's a heat sink effect, especially with radiofrequency ablation. For subcapsular tumors, there's a risk for incomplete ablation and tumor spillage. And near the diaphragm or the colon or other organs, there's certainly a risk for injury to those structures as well. There are also other considerations. Ablation margins matter when it comes to local tumor recurrence. This is data out of MSK in 2016 that showed 2 key points. Margin width matters when it comes to ablation. The wider, the better. And 10 millimeter margin is associated with the lowest rate of recurrence compared to much narrower margins. The other part that was really critical that we need to think about is that cross-sectional imaging is critical to optimal identification of tumor extent and 3D monitoring of ablation margin. So when we looked at this data at MD Anderson, this is our data from our IR attending Dr. Odisio. He has an R01 to fund this 3D reconstruction software that allows him to be very precise with how he ablates. And so when we compare the rate of local tumor progression or recurrence, comparing surgical resection, ablation in the operating room, that's the yellow line, when we did it in the operating room under ultrasound guidance, compared to a completion ablation done by IR in the radiology suite with CT guidance and the software for 3D reconstruction, you can see that the rate of local recurrence is much higher with surgery or in the operating room. The other thing that matters when it comes to ablation is mutation status. So I want you to focus on just the left-hand column there, RAS, for tumors that are less than 2 centimeters in size, which I think we all agree would be indicated, would be okay to do an ablation for. And yet, if you see that in the RAS mutant category, 1 in 3 patients with these small tumors that theoretically should be completely ablated had recurrence at the local margin, which is a huge percent. Does that apply to liver resection? We just looked at that in our institution. Margin nor mutation status seem to matter when it comes to local recurrence. This is a surgical series of 552 patients with a median follow-up of 58 months. When you look at the R1 resection group, now granted, a lot of these were vascular R1, and so we all know that there's a difference between vascular and parenchymal R1, but even amongst that cohort, the rate of local recurrence is 8% at a median of 58 months. And then when we looked at mutation status, it didn't really seem to matter. Whether you were RAS wild type or RAS mutant, BRAF wild type or mutant, all of these other mutations did not seem to impact local recurrence. Then I want to throw in just a quick word of caution about trying to ablate the future liver remnant at the time of right hepatectomy. So this is a series of 227 patients in our experience. A little older data for sure, because you'll see that we used RFA back then. But these were patients who had tumors on the right side and on the left side, and then underwent right hepatectomy or extended right hepatectomy. And they either underwent two-stage hepatectomy, which is our standard of care now, versus one-stage hepatectomy with then attempting of ablation of tumors on the contralateral side, the future liver remnant. And when we looked at this data, you look and you'll see that the rate of post-op hepatic insufficiency was much higher in the one-stage ablation of the future liver remnant side. And it makes sense, right? You don't want to damage your future liver remnant as it's trying to regenerate and grow. So at the end of the day, I think there's certainly common ground. We can come together. And I think Dr. Warner would agree with me that resection is the best treatment for colorectal liver metastases when possible. And as I just demonstrated in our series, when treated with curative intent, R1 resection is associated with a lower rate of local recurrence, 8%, compared to ablation with optimal ablation techniques. Ablation can be considered when resection is not an option because of patient or liver factors, and ablation may be best achieved with 3D imaging guidance, aiming for 10 millimeter margins for tumors less than 3 centimeters. All right, so that concludes my talk. Thanks.